Welcome. I'm going to talk to you today about the pulse oximeter as a source for racial disparities, how we got here, updates from the ISO, and the path towards never again. Here's some of my background and my disclosures. We all come from different backgrounds, we have different life experiences, we've trained in different fields in different locations, but each of us has taken some sort of pledge or oath. And many of us believe that it includes equitable healthcare decision making. And while working in the height of COVID, thinking that you've overcome these sources of disparities from the past and you strive to provide equal care, you see a story by anthropologist at MIT, Amy Moran Thomas, who looked at the history of the device and brought to light some of the concerns about the racial bias that many of us didn't even consider beforehand. So we'll discuss the science of pulse oximetry, the mechanism from a policy and evidence-based medicine perspective, as well as ongoing updates that are underway, and a pathway towards never again. The pulse oximeter was invented in 1972 as a non-invasive approach to assessing blood oxygen levels. It was first used for pilots in the military and later in medical applications. It incorporates basic spectroscopy and assesses the pulse in the waveforms, uses the pulse in the waveforms by using two separate light wavelengths, the 616 nanometer red and the 940 nanometer infrared wavelength. But since its development, even before, there were concerns about bias in skin color. This is a timeline from its development. It became commercially available in 1980 and became standard of care of operating rooms in 1987. There's some research and guidance focusing on the minimal impact of skin pigmentation, but a variety of other studies here below suggested that there was significant concerns about skin color bias. And you see these down here. And there was also a shift from kind of a whole patient evaluation and individualization and physiologic perspective towards this evidence-based clinical decision support approach. And then this led up into 2020 when we had COVID and things started coming to light. After hearing about these concerns, Michael Schoeding and his group started to look at this issue, and as they recognized these similar findings in clinical practice. So he defined a concept of a cold hypoxemia in which the pulse oximeter demonstrated a 92 to 96% reading, while the SaO2 was demonstrated less than 88%. And he looked at this in the adult ICU population, and this occurred in 3.6% of white patients, as well as 11.4% in black patients. Similar concerns were demonstrated in a population being evaluated for ECMO, 10% versus 21%, as well as a pediatric ICU population in which it occurred 15% of the time in whites and 21.1% in black patients. And other studies demonstrate similar concerns. Ian Wong and his group at Duke demonstrated that there was a 70% increased risk of mortality with hidden hypoxemia. He used a slightly different definition, and it was higher in Hispanic and black patients. And Ashfazi started to look down at the downstream impact. And while he showed these disparities, he also attributed that black and Hispanic patients in the early treatment phases of COVID were set 0.71 and 0.77 less likely to receive timely care based on this hidden hypoxemia. And here's another study in a pediatric population age 1 to 17 years old in an ICU, and where white patients had 3% false negatives, whereas 12% of black patients had a false negative group, which would be similar to hidden hypoxemia here. And Vasulis et al. Demonstrated in the neonatology patient population that they had a much wider ARMS that we'll get into, but they had a 9.2% for black patients, 8.9% for white patients, and occult hypoxemia was higher in blacks versus whites. This study here demonstrates the importance of perfusion, or now what's called percent modulation, in its impact with skin color. This study simulated low perfusion states, and in light-skinned patients, they had a 1.1% risk of hidden hypoxemia, medium skin 8.2% risk, and dark skin had a 21.1% risk of hidden hypoxemia. And here are a variety of other factors that contribute to less accuracy in the pulse oximeter reading. So how did we get here? The International Organization for Standardization is a key part of the process. It's a corporation that was founded in 1946 after the UN, and decisions are made between engineers and corporations as well as regulatory and government agencies. And it brings people together from industry to create a consensus. So in order to validate pulse oximeters for use, they use what's called a controlled desaturation study. And this is where they take a normal healthy patient from age 18 to 50 and check pulse oximeters against the SaO2, which is from the arterial blood gas, and do this over the range of from 100% saturation down to 70%. So the current evaluation requires at least 10 patients, which greater than 2 or 15% are non-white individuals. And it uses an ARMS of less than 3 to 3.5% and only requires healthy subjects. And so the root causes of the problem include words and their interpretations of the policies, study design and interpretation, lack of transparency, and over-reliance on evidence-based medicine clinical decision support using this biased data. So in looking at words and meanings, the term accuracy and estimate comes up in regulatory guidance. And so from an engineering and regulatory perspective, they talk about this, what it means is this summary statistic, which is actually more like a standard deviation, which we'll get into. And then the clinician evidence-based medicine perspective, oftentimes we interpret it as an accurate point estimate or commonly not understood. And overall, it oversimplifies and avoids skin color differences, and it's not used in unhealthy patients. This work by Michael Schoeding depicts how it should be interpreted. So on the top, you have a standard deviation curve, which is signifying a 2% random error, which is similar to the ARMS. And then if you had a 2% error and you see 2% of those patients will have hidden hypoxemia if their SpO2 reads 92%. But as you increase bias in B and then increase the random error or ARMS to 2.5%, you'll see a much greater number of patients who will have hidden hypoxemia. Another term of the range of skin pigmentation, from an engineering and regulatory perspective, it was only less than 2 or 15% subjects had to be non-white, whereas clinicians see the broad range of skin colors and assume that there's a wider range. While there are a variety of different skin scales out there, one of the newest, most well-accepted one is the Monk Skin Tone Scale, created by Ellis Monk. There's been a great deal of research on this to try to, it's been well accepted as one that gets at the range of skin colors that's also usable by statisticians. And it's been well funded by Google and Meta to help analyze their digital representation on their images, with their images in their database. At the same time, it's something that's can be used for this purpose. There's also another measures the individual typological angle that uses spectrophotometry or colorimetry, and it's also it's an objective measure of the variation in colors. The term risk from an engineering and regulatory perspective is minimal for this device because it's just based on whether or not there's breakdown in skin color, not on how it actually impacts our clinical decision making. That's on the clinician. And when we look at study design, they were underpowered to detect variation among skin color and never designed to detect accuracy in unhealthy patients. So there's a lack of generalizability to the real world patient. And then we also must think of statistical significance where it didn't versus clinically significant. And as we mentioned, these small percentage differences, when we showed Michael Schoeding's work, they can have a real clinical significance if a a higher proportion of patients are not receiving the best care. So when it comes to interpretation and decision making, we need to apply our educated in human perspective that understand this as the individual physiology as well as the engineering interaction. In order to achieve that, we need education and understand how the devices work and gaps. We need data transparency and statistical transparency, sources of errors, how devices work, and understand the range of certainty. And as we strive to do to follow our practice oath, we might need to, in the short term, we might need to address change our mental thresholds. Do we have higher goals for oxygen saturation levels? Do we need to do additional ABGs or others to get it right for that individual patient? Whereas these protocols that use the simplified algorithms, they have the potential to remove the human perspective and have this lost in translation via the research question, study design, p-values, statistical power, and interpreting and applying the results. And evidence-based approaches often require disease categorization in order to link a predetermined treatment plan or protocol. In the pulse oximeter reading or oxygen required to achieve a certain pulse oximeter is often included in that disease categorization or severity. And so how we interpret the SpO2 is typically a point estimate, and it integrates that biased data and translates into this clinical decision-making support tools or general clinical decision-making, and often avoids potential unintended consequences of doing so. In some of these examples of how it translated into practice include treatment protocols for COVID, home monitoring and guiding somebody on when to seek medical guidance, other treatment decisions, whether or not they qualify for home oxygen, ventilator management approaches, as well as possibly neonatal and pediatric protocols. And the ISO is working to improve guidance. So this would include more subjects using the Monk skin tone scale and or the ITA colorimetry that gets a broader range of colors, improving accuracy such as decreasing the ARMS, and then to evaluate for disparate changes across the range of skin colors. Companies will likely need to submit performance data to complete this table. And as you can see, it's broken down by different deciles of oxygen saturation, and including skin color groups such as the Monk skin tone scale, and the ITA is light, medium, and dark, as well as range of percent modulation, or what's considered to be perfusion. And they will also likely need to submit data within these to assess for non-disparate assessment across skin colors, to compare these darker skin color groups to the lighter skin color groups, and strive for less than 1.5% or less than 3.5%. These numbers are up in range, and how detailed, or they might just need to be transparent related to this to purchasers and users of this. And the same will go for the ITA, which is a more objective measure. It will be clear that this patient places all the responsibility on the clinician and user for interpretation of the oximeter. There will be more details about device descriptions and specific use case scenarios, and whether or not something's prescription or over-the-counter, single-use, multi-use, and here are some others listed. There will be more information to educate clinicians and users on about its use, such as using the device on the specific site location, such as ear, finger, forehead, or to evaluate the signal quality, such as percent modulation and waveform, as well as waiting for 30 seconds to get an accurate read, as well as other concerns. While they will still require only healthy subjects age 18 to 50 to undergo testing, they will request pediatric population data from convenient arterial sampling from these separate groups, neonates, infants, and children, and to incorporate this type of data to be analyzed and potentially to be shared with purchasers. There will also be some labeling for over-the-counter use, such as reference normal physiologic ranges and when to seek timely medical attention. And there will be some general performance standards, but without details. And we should use this as a path towards never again for pulse oximeter-induced racial disparities, as well as potentially think about broader new technology and software-based disparities. And remember that even the most accurately evaluated SpO2 reading is still more of a standard deviation that likely has some disparate bias based on individual characteristics. And we should think about this when we use different set criteria that incorporate the pulse oximeter reading in our clinical practice decisions. And while I'm not a pediatrician or neonatologist, there are specific protocols that use the pulse oximeter for screening of critical congenital heart disease, as well as used in neonatal resuscitation and other therapies. So apply this understanding of the statistics for your individual patient. So in addition to keeping your whole human perspective, consider looking into options for independent data collection and laboratory evaluations. Historically, the desaturation studies have been done by nonprofit labs, but now it may be moving more towards for-profit labs, and to look into more transparency of the data. And I just want to highlight Michael Lipnick's work out at UCSF with creating openoximetry.org to help do some of this independent data collection and pilot some of these approaches. And we need to be vigilant with post-marketing analysis, real-world studies, and to identify when there are still ongoing gaps, and to engage administrators to choose the best devices based on the data. In this community, trying to solve this issue, a number of us recognize that how we handle this issue can be a model for so many other similar technology and software-based issues impacting both health and humanity. We are at a crossroads with medicine and health. And while this little girl that we're focused on making sure that she has equitable healthcare decisions, she also brings up a big question for all of us are grappling with. So she's in a Wired magazine video where they have leading experts, and in this example, there's a Harvard computer science professor is explaining computer algorithms to a 6-year-old, and she asks the questions that many of us are asking subconsciously, but not addressing this out in the open. And that, are we going to maintain control over the computer, or will it control us? And even as technology advances and develops, we have people like Geoffrey Hinton, the godfather of AI, and other people who are concerned about having the technology guide our decisions, taking over our decisions, as opposed to us using them with a humanistic lens. At the same time, there are sources of wisdom followed by billions of people around the world that may provide some guidance to help ensure that humans stay in control of the computers and not the other way around, or in this case, the software. And just to highlight this again, if you're not at the table, you might be what's being served for lunch. And so the solution is to maintain our common guiding principles and to make sure we have a seat at the table. We may not be able to control every aspect of a device, but at least we'll be able to be closer to the truth, to understand the gaps in the science and gaps of understanding the words and terminologies to best apply these principles to our practice. We cannot wait for decades or rely on other researchers to uncover the next technology divide decades after it's been implemented into our practice. So for all software devices that influence our decisions, we should understand the basic scientific principles of the device and the software, and the description of the device, inputs and outputs, and the data used to create the software or decision support to preserve our human deep thinking, and not just hand it over to artificial intelligence or technology, and to be a blind spotter, to identify potential unintended consequences and maintain our role and care and engage administrators. We need to understand the source of the data used for the software, recognizes how it influences our decisions, and recognize the blind spots of the corporations and the regulators, and identify and remove harmful policies. So to summarize, a path forward, an approach to never again, to be a blind spotter, share the insight with the clinicians, or use your insight, recognize variations in words, meanings, and perspectives that create problems, understand how the technology works, its limitations, and how it influences us, recognize study design and limitations, and educate the next generation, and monitor to identify harmful policies. Be a voice to maintain and preserve our professional oath to heal all. Thank you. Thank you to the researchers and other advocates. Thank you to the ISO partners. There are really good people who are trying to work on this issue and balance different agendas. And thank you most of all to our creator, the source of the evidence-based safety checklist tool that time and time again has served to preserve and restore humanity.